Good morning, everybody. Welcome to Grand Rounds. I'm Howard Chansky, the chair of the department, and welcome to our faculty who are watching remotely. A couple of housekeeping announcements first. Everybody should have got an email that on October 25th at Swedish is their annual joint replacement lecture. That's sponsored by Jim Crutcher. And this year it's going to be Seth Jerabek from HSS who's going to be speaking about functional positioning and total joint replacement surgery. And then also one kudos for Andy Hewlett, and it's from Chris Moe. And everybody knows Dr. Moe is an otolaryngologist who runs facial plastic surgery at Harborview. And Dr. Moe said Dr. Hewlett did a workup on Dr. Moe's child, and he was absolutely fantastic. He was great with our kid, fantastic clinical skills, really nice to us, explaining everything and reassuring us as appropriate. I'd certainly be proud if he were one of our residents, and I'm sure he'll be great for the reputation of your program in the future. So thank you, Andy. One other announcement, we have Jared Harwood here for his first Grand Rounds, and Jared is our new orthopedic oncologist who's starting in a couple of weeks. Welcome, Jared. And then this morning we have an old friend of mine who, somewhat sadly, I figured out this morning we actually go back about 35 years. Not a great thought, but it's really great to have Brian Sennett here. And I'm going to have Albert introduce Dr. Sennett, Dr. G, of course. And Dr. Sennett actually trained quite a few people here. We were in our residency together. He trained Dr. G, trained Dr. Shu, and Paul, where are you? And Paul, what is your last name? Reynolds. Paul Reynolds is another former resident of Dr. Sennett's. And Paul is up in the Everett Clinic, is that right? Working with Cliff Ho, one of our former residents. And the only other thing I would say is that we owe Dr. Sennett because when I was vetting Dr. G, when we were thinking of hiring him, I had Brian on the phone, I think probably twice. And he really was a big, huge supporter of Dr. G's and also of Dr. Shu's a little later. And maybe he helped Albert overcome some of his concerns about moving to the Northwest. And with that, I'll have Dr. G do the formal introduction.
So thanks, Dr. Chansky. Good morning, everybody. Welcome to Grand Rounds this morning. It's really a special day for me. Very excited to have Dr. Brian Sennett here to give Grand Rounds. And as Dr. Chansky mentioned, he is a wonderful mentor for me even now and was for us during residency, including Dr. Jason Shu as well. So just to give you a little background about Dr. Sennett, he's a sports medicine surgeon at the University of Pennsylvania. He's the division chief there, and he's also a vice chair within the department, as you see here on the screen. But prior to that, I think he spent a couple years here in Seattle. He was telling me when he was quite young and was actually born here, so it's a bit of a kind of a homecoming for him, I guess, of sorts. He did his college years at Brown, where he was a student athlete, excelling in both, I assume, the classroom as well as on the baseball field. But I don't know all the details, but I think that the majors probably didn't come knocking down your door, so you then chose a life in medicine. And I forgot, were you a catcher? Is that?
I caught in high school and played outfield.
Outfielder. Okay. And so I remember fondly that Dr. Sennett was always very amped about fantasy baseball during residency, so I knew that he had a strong connection to baseball. But anyway, so then did his medical school and residency at the University of Pennsylvania with Dr. Chansky. And then actually did two fellowships, one in sports medicine and one in hand surgery, and then joined the faculty again at Penn a number of years later, where I learned from him quite a bit. And he's now the head team physician for University of Pennsylvania Quakers, their athletic team. He's also a team physician for the Philadelphia 76ers NBA basketball team. And I think, you know, his list of accomplishments and awards is quite long, but I would bet that one of the kind of the, I don't know about the accomplishments that he would hold and kind of find, what's the right way to put it? The accomplishment that he would cherish the most is that he's the winningest faculty member when it comes to the residency teaching award at the University of Pennsylvania for orthopedic surgery. I'm sure it's in double digits. I know it's in double digits, and I think for a while there was like a stint of maybe 8 years where you won it every year. It was like when I was a resident and Jason was a resident at Penn, it was like a foregone conclusion. It was almost like a joke at the end of the year when we got to the banquet and we were waiting to hear about who was going to win the faculty award or the teaching award. It would be Dr. Sennett. So, and that was obviously well-deserved. He was an incredible teacher. Tuesday morning teaching conferences with Dr. Sennett were a wealth of knowledge and quite an anxiety-provoking experience too for the residents, because he was a hard teacher, but that's how we learned. And in the OR was the same way. Incredibly great patient teacher, but also very exacting, precise, and very high expectations for his residents. And he would never let you get away with anything, and he would never not let a resident meet the expectations in arthroscopy that he thought was needed for a resident graduating from Penn. So it's the reason why I went into sports medicine. He's the reason why I'm here now. He's the slickest knee arthroscopist I've ever had the pleasure of working with. So it's really special for me to have him here, host him here in Seattle at our institution, where I teach you guys how to do knee scopes, and a lot of what I'm teaching you guys are the things that I learned from Dr. Sennett. So that's really special for me. And to have him talk about advances in arthroscopic education, I can't think of a better person for that. So please help me in welcoming Dr. Sennett here for our grand rounds.
I assume my mic's on. Well, this is a great honor, and it is very a special, passionate area for me. Some people ask me, why do I stay in academic medicine and why not be in private practice? And really, it's about residents and education. As I was preparing for this, of course, Albert gave me a topic to talk about that. Of course, I had no slides on. It couldn't have been like PCL or ACL or meniscus, but it was a lot of fun really going through it. And I went through and did the math, and I've had about 50 residents that have gone into sports medicine fellowships. And it's been fun watching them populate different parts of the country and being so successful. And it's a lot of fun being involved in education. So my charge today is to talk about kind of arthroscopic education at a high level, and then a little bit of what we've done at Penn. And it may even inspire some of the things that you may end up doing here. And so, just get this thing clicking along. And so this is just a little picture. This is how I taught LG. We worked on sheep knees. We never let Al work on humans. And so I'm just kidding now. We let you work on two. And so, but this is in the lab. Al spent a year in the lab, and we were working on arthroscoping sheep knees. This is Dr. Mock, who's kind of the brains behind a lot of our tissue engineering in our program at Penn. Where am I pointing? Going off this list? I can do it this way. So as we're going to basically go through, we're talk about how do we become an expert, what the challenges that face us, how do we get proficient given today's culture and time, and how potentially you can be involved in your own educational process. So we're going to start off with a simple case here. So this is a 56-year-old right knee, a gentleman with a right knee problem. He comes in, he has pain in the medial aspect of his right knee. We go along the conservative approach first. We treat him with therapy. I think we even did a cortisone injection. And he just kept having pain involving his knee. So now we're getting to that point where he's starting to fail the non-operative approach. His pain is kind of localized on the medial aspect of the knee. The knee's very geographic. Where your pain is typically where your problem is. So one of my great things I tell people when you're examining is just ask them to point where the pain is. And if you know every anatomic structure underneath the finger, you got a pretty good differential. So we end up getting an MRI of his knee. Where's Aditya? Is Aditya here? Oh, there you are. See, you didn't think I'd know your name, did you? Huh? Okay. So what do you see on this MRI, Aditya? So right in this area here? Yeah. And does it communicate with the articular surface? Like, does this gray line go all the way through to the bottom? Yeah, pretty close, doesn't it? Yeah, that's what you said, right? You're good. But it's subtle. It comes right down to that location. Do you think this is the medial side of the knee or the lateral side of the knee? Yeah, why do you say that it is the medial side? Why is that the medial side? Good. Okay, so we don't see the fibula. We see a little bit of concavity of the tibia here. The medial meniscus, the posterior horn, is bigger than the anterior horn. And we also see some of the semimembranosus coming into the back there. So there's definitely clues that we have that this is the medial side of the knee. And we can look at our anatomy, and we understand the anatomy. We can see on these pictures here, yeah, the medial meniscus, the posterior horn is much bigger. The anterior horn is relatively small. You almost will never see an anterior horn tear of the medial meniscus, and they pretty much are always lateral. Whereas on the, posterior, where on the lateral side of the knee, a lot of times you'll get tears of the anterior horn because it's more of a 1-to-1 ratio. The size of the anterior horn is very similar to the size of the posterior horn of the lateral meniscus. And so this is when we arthroscope the knee. So we see here on this picture here, we got the, this is a coronal image. We can see the signal change through this area here. And we eventually arthroscoped the knee, and he had this tear in this location. Do you think this is going to be a repairable tear? So here's the vascularity. We'll go with Megan. Where's Megan? There you are, Megan. So Megan, there's the vascular. I'll give you a little heads up here. So the vascular, we think of that medial meniscus. The medial meniscus is a little bit more vascular than lateral meniscus. Counts for about 20 to 30%. Lateral meniscus is about 10 to 25%. It's out peripheral. Then we're going to go back, and we're going to show you a video here. And then, let's get this video started. So this is the arthroscopic video of it. And you see he's got some condyle changes on the medial femoral condyle, consistent with maybe a 50-some-year-old knee, probably like the inside of my knee. Oh, you got the wrong video, but that's right. We're gonna go with this. So where is this tear on this video? Yeah, so this is the posterior horn. It's right where it attaches into the bone. So this is a root tear, okay? Do you think this is a repairable tear? Yeah, it is, because when you curette that area right beneath that area, it's going to turn into bleeding bone, and then you could put stitches in it, and you could repair that into that area. Now, we'll probably sneak back later on, and we'll come back to the other video. They were loading this one, they got flipped. So this is a root tear bulge, and it doesn't match up exactly with that other tear location. And so then the question really comes on, if it was the one that we've seen before, we would have trimmed it and trimmed out the tear. And so that leads us to thinking, how comfortable are you with that? Where's Mark? All right, Mark, you get to pick a chief resident. That's all you have to do for your question. Pick a chief resident that I'm going to pick on. Claudia. Is it Claudia? Where's Claudia? Oh, you dimed her out. Claudia, wherever you are, this question's for you. So picks up. Now we're going to give you a more challenging thing. Pick someone who's actually here. Adam. All right, Adam. Remember, next time you're on call, Adam, you know who to get. Okay? So how comfortable would you feel doing that meniscectomy? LG says, you know, I'm not feeling too good today. I don't know if I can finish this case. Can you finish it? Okay. Could you do it without scuffing up the condyles? Okay. And could you fix that root repair? Okay. And so this was a study looking at it, and the real question is, how do we get proficient? How do we get to that point where as a chief resident you say, I can do this. I feel comfortable with it. I feel confident with it. If we look at fifth-year residents, about a quarter of fifth-year residents go into sports medicine fellowships. Okay, sometimes it hovers back and forth, but there's about 190 sports medicine fellowship spots. Some are taken by international medical graduates, but many, or it's about a quarter of the residency population goes into sports medicine fellowship. Some people say it's because residents get done, they just don't feel quite proficient enough. So how do we get that proficiency? When you look at boards, 50% of people report that it's a significant part of their practice. So arthroscopy is not just a specialty of sports medicine, but it's part of what you do. So proficiency is driven by confidence, okay? And then What gives you, what builds confidence? Let's go with Casey. Where's Casey? Casey, how do you think you get confident with a procedure? That's right, volume. So, and this week, I was just so excited to come out here this week because it's your boot camp week, okay? And this afternoon, I'm going to get to spend a bunch of time with you in the lab, which will be a lot of fun for me. Hopefully, it'll be a little bit of fun for you. And but the getting volume, and so that's real important. This is what graduating residents look like when you look at your case logs. And Dr. Chansky says, "Did you get your case logs in yet?" I know that's what we do at Penn. When you finally fill them all out, this is where it looks. And at the end of the year, now this is going back, this is a study that was published around 2016, but you can see the trend of how many arthroscopies are done. At the 70th percentile of respondents, they're a little over 200 for knee arthroscopies for their 5 years in residency. And the 30th percentile puts them in here. So somewhere about 170, 175 cases is what you'll log during that period of time. This was a study looking at how confident are those chief residents. So was it Adam? Yes, when Adam talked about his confidence level, these are the things that they looked at. They looked at these are basic procedures. Notice this is not an ACL reconstruction. It's just doing the ACL tunnels. And if we look at this, diagnostic, loose bodies, partial meniscectomies, lateral releases, here's a great thing. Program directors always think that you're getting to do more than you actually are, okay? And when we look at confidence, they think you're more confident than you actually are, okay? When they looked at these things combined, confidence always dictated the amount you actually got to do. So when you're confident, you'll demonstrate a certain perception by your attending that you understand what's going on and you know how to do it. So it's always the question, how do we get confident? And that's about, for the education, we have to build that environment, helping you get comfortable. This was an interesting thing that came out of that article. And it's something we struggle at Penn ourselves. As much as I love sports medicine education, I'm just one guy. I'm the vice chair, but I'm just one guy with one voice. I have 3 faculty members that are also sports guys. But we're battling the spine guys and the foot and ankle guys. And we need more education time. And if you look at these, if you do 5 to 10 months of your residency and you're exposed for over 5 months with arthroscopic education, 60% felt they had enough training. If you did less than 5 months, 4 months or less, only 20% felt they had enough education. And then they looked at how do you feel compared to like you're doing a total knee, and that's what they use as open technique. So if you're doing your 5th-year resident, and you're saying, and this one on this side here, this is a 2nd-year resident, this is a 5th-year resident, how do you feel comfortable you feel doing these arthroscopic procedures versus doing a total knee replacement? And we looked at our own stuff. We have 10 months, I think it's 10 months, almost a year of people doing knee replacements at Penn, and of the 4 clinical years. So we are constantly bashing our joint guys, we need more arthroscopic time. And they say we need more joint time. So it's always a battle on education and where it goes. And the ACU-GME has not ever come out and said, you absolutely have to do these many rotations of this. They have some, maybe like pediatrics and things like that, but not in the worlds of arthroscopic. So a lot of residents get done with the residency program, they don't feel quite as confident. So the question is, how do we become experts in arthroscopy? All right, let's go with Mark. Did we get Mark? No, let's go with Greg. Where's Greg? Greg here? Greg, you know who this is? Does anybody have an idea who this is? Yes. And so, wrote book Outliers, and yes, Malcolm Gladwell. If there's one thing out of this book, one line, what is it? Does anyone know? So, what makes an expert? 10,000 hours. So the concept is, in his book, is that if you do something for 10,000 hours, whether it's play the piano, kick a soccer ball, play the harmonica, whatever it is, arthroscope a knee, if you do it for 10,000 hours, you can become an expert, okay? So, I kind of thought about the math a little bit. And I say, okay, I have a resident done my rotation, 8 hours, 2 days a week in the operating room. Okay, we're up to 16 hours. They're with me for 6 weeks. Okay, we're up to 100 hours. That's a little short, okay? And right now at Penn, we have 2 dedicated sports medicine blocks, a PGY3 and a PGY5. Now, they get a smattering at the VA. They'll get a smattering at Children's Hospital. But that's where we push. It's like, how do we get up to get that proficiency level up? So, anyone know who this is? Now I know you think that they stopped the video, okay? But watch his pant legs, okay? Watch his pant legs. Hopefully it's gonna play again. And you'll see the wind's blowing. The video's not stopped, okay? So the question is, and look at him, watch here, this is really great. Hey, I like that shot, okay? That's kind of like arthroscoping the knee, kind of like this, and going, hey, I did a pretty good job. And so if you gave him this little Harvey Pennock's Little Red Book, which is a classic little golf book, would Charles ever become an expert? He's probably paid golf for 10,000 hours. Some people may not become experts, okay? But you can. And so what are the challenges? And as I started to make a list of the challenges that you face with arthroscopy, I realized, wow, it's almost like hitting a golf ball. If any of you have ever taken a golf lesson, okay, you stand here like this, you put your hand here, you put this hand over the top, put this arm in, tip like this, and you go, and then you get here and they say, okay, now relax, okay? And you realize, geez, so I started going through it. You need to be ambidextrous. You need to be able to hold the camera in both hands. That's challenging by itself sometimes. You need to understand portal placements, how to control a camera, how a camera works, fluid management. The thing we never talk about, and I don't really ever talk about, and when I was preparing for this, it really made me think about it a little bit, is you're looking at a three-dimensional structure on a two-dimensional screen. There's no 3D vision. It's not like you put 3D, oh, there it is. So when you're reaching in, and how far do you reach in to get that meniscus when you're with a biter? Triangulation, everyone talks about triangulation. You got to manipulate the limb as you like, if it's a knee moving around. You got to be able to use the equipment inside the knee. You have to have what's horizon control. Sometimes when we're arthroscoping, I'm kind of watching the resident, and it's kind of like the lateral side of the knee is kind of like this because the leg's in this position and the camera's sideways. And I'm not sure if it's horizon control on my head. Actually, I got vertigo a few months ago. Now, and when I was thinking, maybe it was from that resident, but it's gone, so we're good. And then arthroscopic skills, things like tying knots. That's not a challenge. So additional challenges, and this is where it really comes into 2018, work hour restrictions. At Penn, we've collapsed inwards. We have to think about work hour, and it's all across the country. We stopped doing stuff in the evenings. So like 6 o'clock, like the day is done. Evening stuff is gone away. Ambulatory surgery centers, we open these beautiful new buildings, and this is where, for many years, and I worked over at Penn Presbyterian Medical Center, and this is the new trauma center they put in. Right across the street, we built this building. It's the musculoskeletal center. And up on the 5th floor is the ambulatory surgery center. The rooms are huge. I don't even know what to do in the room. It's like, it's like a cardiac room size. And everyone goes, oh, this is going to be so great. Yeah, until you realize that the doors have to close at 5:30 and you got to be out of there and you're still trying to get 7 cases done. And it's an academic day and you don't start in the OR till 9. It's like, wow, we got to move. Okay, moving is against resident education. Okay, back in the Al and Jason days and Paul, we used to hang there, and I remember it would be like 9:30 at night, and the only question was Dr. Okereke, our foot and ankle surgeon, or me? Who's going to be done first? Because we didn't care what the end of the day was. It was like, all right, it'd be 7 o'clock, and all right, Al, let's make the portals, and and there was no pressure of time. So ambulatory surgery centers have compressed it. Work hour restrictions have compressed it. How you educate, like at Penn, we've gone to a 4-hour Thursday morning block, where on Thursday mornings, it's 6 a.m. till essentially like 10 a.m. The residents get to the OR around 10:30. Well, there's a couple cases that with me, they usually were there on Thursday morning. We missed that. And arthroscopy is going to change. I don't do anything exactly the same way that I did many years ago. So while you're trying to learn, we're learning as well. This is what we're faced with at the end of every 6 weeks. We're faced with this, and basically it's our competencies that we fill out. And I always kind of chuckle when I'm filling out. We have some attendings, they just give the residents all 5s. And then you read, it's like capable of performing meniscus transplants. It's like, and so we always kind of bash our young faculty who just click 5s on everything. Most of the time, I'm always in a level, looking at a level 3. And I have PGY3s, and this is what we really think about arthroscopically. Are they capable of performing diagnostic arthroscopy and meniscal debridement? If you remember that slide I showed you earlier about assessment of how confident residents are, it was really about very basic arthroscopic skills. Very rarely do we get to these capable of performing meniscus repairs, all techniques, open and arthroscopic. I don't even do many open repairs anymore, except for meniscus, when I do meniscus transplants. But it's really these combinations of these things. This is where we're trying to build proficiency. So as we are becoming more of a competency-based education program across the country, there are different things you can use, and I think these are worthwhile. There's two different ones I just kind of picked as examples. This is the ASSET, which is the Arthroscopic Surgery Skill Evaluation Tool. It was devised around 2013. And it basically kind of gives you things you're striving to accomplish. So you can kind of say, like sometimes, how do you know you're done? Because you've checked everything off on the list. And sometimes, so you have to have a list. So back in the old days, I would just go, we're going to do this, and this. Now I kind of say, all right, when I meet with residents, I say, these are the tasks we're going to try to get you through. Now we still do it with my guidelines of how we go about doing it, but these are things, yep, got that, yep, got that, yep, got that. And if you have a system like this, you can actually see, this was the dark ones are the experts. Experts is like an attending or attending level. And this is pre-training, beginning of a rotation. This is the end of the rotation. And you can say, this is a tool that you can actually measure improvement, which is kind of neat. And so that's one. And this is one out of HSS. They use a checklist intervention. It's very similar, but they also put some timelines on it, on recommended time, on how long it should take these. These are all just diagnostic steps of an arthroscopy. And most PGY3s, I meet the first day, I try to set their goals and their outlines, and they say, and I say to them, I know what your main goal is for this rotation. You want to walk out here and feel like you can arthroscope a knee. And they all go, yeah, that's exactly right. and if they walk out 6 weeks and go, I can arthroscope a knee. If I go into another doctor's OR and they said, you've worked with Sennett, right? And they go, yeah, well, can you get started on that knee? I want them to be, I can do that. I want them to feel confident, and I want them to be moving towards proficiency. If we don't get enough time and we don't get enough volume, how can we augment this to learn more? And so it comes into this whole area of arthroscopic simulation. And the last thing I will talk about is virtual reality simulators. And we're on the verge of trying to get money together to get one at Penn. I can tell you the module that we're getting, it's like, for me, I'd be happy if we just get the knee and the shoulder. But then we got the hip guys, we got the shoulder guys, the elbow guys and the wrist guys. You take the whole thing, it's about $200,000, okay? It's not a cheap thing. So the question is that what simulation is? Well, there's a lot of other things. There's low-cost simulators, there's arthroscopic models, video, printed material, cadaveric training. That's actually the favorite of residents. Residents like what you guys are doing in boot camp. If you give them this or you give them this, they would rather have this, okay? And so we'll talk a little bit about that. What are the advantages of it? This is one of the biggest ones. You can make mistakes. Boy, I can tell you, when I work with our residents in our cadaver lab at Penn, I'm like a different person. Like, yeah, just go ahead. Yeah, the goal here is to get to there and get to there and there. And we're not worried about every single articular cartilage blemish that we do worry about in the operating room. Shortens your learning curve. Everything you learn outside of the OR makes you learn quicker inside the OR. And it gives ability to assess how residents are doing. It helps us train residents. And ultimately, if you do a better job, you fit these last two, which are sometimes the things that you can really drive change with, improve patient safety, because it's always about how do we make things safe for our patients, both during residency and when you become attendings. This is a real simple thing. It was devised in England, and this is just a simple little plexiglass box. They put some of these grommets in these things, and these are little silicone washers, I think, you go through. And they put these little things, these are just little hooks that you can flip over. They glued them to the bottom, and then you flip the hooks over in, and you put a rubber band around them, okay? Well, that's pretty simple. And you hitch it up to a little camera that goes to the computer, and the whole thing costs $72 to make, okay? So this is a real simple thing, and it's been shown that you can, with this simple little tool, you can differentiate between medical students, trainees, which are residents in England, and consultants, which are attendings in England. And then you can also see that you can learn, there's the first attempts and then the last attempts. And even the, quote, experts improved with these learning techniques. And with each attempt, they got better and better. The medical students never got better than the residents never got better than the attendings, but everyone continued to learn. This is one that came out of the US, but again, $79. So these are cheap, relatively cheap. You can go to Home Depot, maybe not, you gotta get the computer somewhere else, but everything else you get from Home Depot for a total of $79. And what this is just, this is like a PVC pipe that you're gonna put in your ground. You drill the holes into the PVC pipe. and it rotates. So here it looks like a knee. These are the two anterior portals of a knee. If you're doing something on a shoulder, it's an anterior and a posterior portal, and you can do tasks that way. And so this is just, they just did a few different things in the paper they wrote. Moving pegs from one side to the other and then back again. Doing from these front, this simulates knee motions. This simulates shoulder motions from an anterior portal and a posterior portal. This was just simply putting it into like a lateral position of knee and drawing a circle. You had to draw and stay inside these two lines. And this was just retrieving sutures. And again, with these tasks, you were able to differentiate between levels of training, and you could actually see improvement. So these are really inexpensive things that you can use to work on your hands. It's like, if you work on your hands before you get to the OR is going to be less stressful. And that's a big thing. You know, when you go in the first day in the OR and you're doing stuff, and holy cow, you remember all the list of all the things I said? Ambidextrous, you know, arthroscopic knots, all these different things. If you already have this in your bag, like, hey, I can move things around, I can do this. It doesn't really look like a knee, that PVC pipe, or a shoulder, but it teaches you some of the basic skills. This is our dry lab at Penn. And this is one of our, he's actually attending now down at the Curl and Job Clinic, Christos Fotopoulos, and Christos did this, okay? So I'm going to show you three big things, and they are huge contributions from our residents. And so I said, be involved in your own education. So Christos just went out and he talked to different arthroscopic companies, and he got people to donate things, and he got them to donate old arthroscopic equipment. And this lab literally costs nothing to build, but we have like arthroscopic knot tying stations. We have things to pass through rotator cuff sutures. We have different models that are essentially we're getting thrown away at different places. And this has been put together. I think the truth is this cost about $1,000 to put together. And it's basically a dry lab station that we use. It has the video monitors. And it was basically something that one of our chief residents put together. And again, it eliminates stress of getting into the operating room. And he was a PGY5 when he put this all together. We open this, and then the question is, okay, now you've done all these skills. What about getting into the operating room? What's the next step in this education? You got some skills, but what about the patient? Okay? Now the residents always want to know, how do I do it? Just tell me how to do it. So we have the 10 Commandments. They want the 10 Commandments. I don't have 10 Commandments for them, okay? I have my 10 Demandments, okay? And so these are the things that I think about, okay? Now, what do I care about? Number one, it's arthroscopic. It's skin in your inside. You still got to know where the portals go. So you have to know your surface anatomy. You have to know where that tibial tubercle is, where the patella tendon is, the patella in the shoulder. You have to be able to feel a coracoid. You have to feel a post-lateral aspect of the acromion. So you need to be able to feel surface anatomy and get it right because your portals are based off that. You also have to know what's between the skin and the deep tissue. You have to know where the nerves are. You have to know what's beyond it. If you're drilling a pin, if you go too far, are you in danger land? You got to be gentle, okay? Arthroscopy is gentle. It's not like just get the thing in there. It's gentle, gentle, gentle. This next one, thou shalt believe. What does that mean? Anyone know? Let's go with Andy. Andy, are you here? Good. All right, Andy, you look like a purveyor of fine art. Do you know what this is a picture of? How about, do you know who this is? That is Jesus. Do you know who this is? It's actually PGY3. Okay? So it does look like it. This is actually, is basically painting of when he healed the person that was deaf and couldn't speak, okay? And so why did I put this in there? You have to have yourself open to education, okay? You have to have your ears open, you have to have your eyes open. You have to believe you can do this, okay? I have residents that do come over to that, about 1 out of 8. We also have 8 residents here. I have 1 every 8 every year who goes this, I'm just not good at this. I'm just not, sometimes they say, I'm just not great at memorizing. And I say, you got to be kidding me. We don't even look at it if your USMLE scores aren't over 220. You have to memorize. You have to do these things. You have to come and say, I can do this. This is not hard. Okay, arthroscopy, but it's a set of tools that you've never been exposed to. So all your life you pick up a coffee cup, you look at that. It's not like you put your head down here and you kind of get up here and you try to pick up the coffee cup. That's what arthroscopy sometimes like. But you can do this. So you have to believe you can do it. Replication of angles. When you make a portal, every time you just come in and out the same way. It's real simple. That's the path of least resistance. 2 points make a line. When you make a portal, you think, okay, that's going to be one fixation point. You got a condyle. If you want to see around the condyle, make a straight line. Are you going to be able to get around that and see? Maybe you need to move the portal over. So you have to think about how the lines set you up for your next thing. You'd be able to visualize. And when I put visualize, you need to be able to just see what you're doing. So if it's bleeding, if there's synovium in the way, you have to get that under control. You have to be able to visualize. But you also have to be able to visualize what the end product is going to look like. How am I going to get there? How am I going to fix that root repair that we showed? You need to understand the pathology and whether things are repairable or not. You need to know your arthroscopic tools. And you always, even to this point in my life, you have to strive to improve. But we constantly do new techniques. Like I do anterolateral ligament reconstructions at times for ACLs. I didn't do them 10 years ago. So it's like, first one I do, I write down where I struggled. Next time I do the case, I pull out where did I struggle. Try not to struggle in that spot anymore. You constantly have to strive to improve. This is put together by our Penn residents. And so we have and you may have something similar to this. One of our residents put together a web page, and basically it's all stuff for the Penn residents. You have to log on to it. I figured out how to log on to it, and I kind of got in and looked at everything. I actually only needed my Penn key, and so I realized I actually do have access to all this. So if you log on to this website and you basically go through this process, you can find what the simple steps are for Dr. Sennett's arthroscopy. Okay, this is page 1 and 2. This is page 3 and 4. This is page 5 and 6. I never knew it was so long, you know? And so I was like, and I started kind of like, no, this is way too many. There's over 100 steps here. In my brain, there's not 100 steps, but this is done, you know, somewhere Jason added to this, somewhere Al added to this, and it's just continued to grow and grow. Probably another 10 years, it'll be about 20 pages for a knee arthroscopy. But these are the steps, and these are helpful, though. It gives you steps, it gives you direction. So every residency program does something like this. It might be a set of papers where it's written down and the resident hands it to the next resident, or maybe something that it sits on a website. So this actually sits on a website at Penn and goes through the whole thing. But then we go to the next level, and one of our residents, and his name is Jonathan Datillo, he was a PGY5 now. He started this when he was a PGY4. He started at Penn a whole surgical video library, okay? And he has taken upon himself to be the spearhead to actually video all of our procedures that are commonly done. So he's taken first started with the most 10 common procedures. So he said, Dr. Sennett, hey, can we film your knee arthroscopy? And I said, sure. And so this is a credit to Jonathan Datillo, current PGY5, started this problem when he was process when he was PGY4. We'll see if this will play. And so so the residents, they basically have access to this video. It has, you know, if you don't want to have the volume on, they have closed caption or like that. And basically, the thing that, Al G was real nice. He said, Dr. Sennett, he's very slick. I never knew my hands were so fast. I look at my hands, I was like, and this video was slowed down, so. And so as we go through it, though, and see if I just jump around a little bit, you can see a little bit. It goes through the prep, and then we get to the point where we talk about just injecting the knee. We talk about all the surface landmarks. This is all being narrated by myself. And basically, this is a whole system. Let's jump forward. And this is probably things that, like Al will look at these things, and you'll remember a lot of the stuff that we used to do. And basically, it's a whole thing of a knee arthroscopy. And we've replicated it for carpal tunnel, total knee replacement. We're getting ready to do ACL reconstructions is the next thing. And so it's a really nice way that the residents can, some are like to read all the steps. Here you can see all the steps. Again, this was resident driven. This is not me doing all this stuff. This is the residents basically saying, we want to improve our own education. And so there's it's a really good way, and so we're excited that we've done it. This is kind of brand new, so we did this about 6 months ago. And so then the thing is, all right, what else can we do? And so we move on to the cadaver training. You guys are doing the boot camp, which is great, and what's great about your things I was thinking about is it's 3s and 4s, and the 3s, you obviously then do it 2 years in a row, which is nice because you're mentally different another year down the road. And also repetition is important. So doing a task is great, but doing a task multiple times is even better. And so when Dr. Scott Levin, who's our current chair, came to Penn, one of his only, like, I have to have this clause. It wasn't about salary. It wasn't about life. His only thing was he was the one that built the human tissue lab at Duke when he was down there. He said, I have to have a human tissue lab at Penn. And so we got this space, and they built out all of these stations, and it was beautiful. It was great, and we had no arthroscopy. And so it was like, okay, this is great, but this is what we want. We want arthroscopic stations. We want drip pans. We want to be able to put cameras in. We want arthroscopic pumps. And Milton Zagonis is one of my partners now. I had no intention of hiring him. Was he in your class?
Yeah, he was.
And so it was around the time of Val, but we had no idea of intention of hiring him. And, and he was going to sports fellowship. We had no need at that point. He was going to Duke. But as a chief resident, he said, it's really a shame we have this beautiful lab, and we don't have any arthroscopic equipment. So he went and he wrote grants. He wrote grants to all these different companies, and he secured $580,000 in funds. And it was all through grants. Industry they've been very supportive for you guys for this boot camp. Industry can be very supportive, but you have to go through a lot of rigmaroles. This resident, Milton Zagonis, is a PGY5, was very committed to that. He wasn't coming back to Penn. He was leaving. When he left as a PGY5, he secured all the funding and then he left. Okay? And so he was never even going to benefit this, but he was going to leave it behind. And so then things changed at Penn. Some openings happened, and we hired Milt. And Milt's one of my partners. He's about 5 or 6 years in practice now, and he's the associate director now of the Human Tissue Lab. And so we use this, and we use this regularly. We have a curriculum, so it's great to have labs. Like you guys have structure this week. You have to have structure when you go in the lab. When we run a lab session, it costs us $2,000 approximately, about $1,800 for every session that we run. And we run them we have a basic thing. We run them in 6-week blocks for the residents, and we have things, the tasks for the residents to do along the way, and then we also have tasks for our fellows to do. And we repeat it. Now, the truth is that for the fellows, we keep changing it a little bit along the way as they go through the year. And what we try to do is we try to do arthroscopic things, and then we do things like we may do something with a meniscus repair on the lateral side of the knee and say, all right, let's dissect out the posterolateral corner, see where that common peroneal nerve is, see where the ligaments are, how far are we away from things, or PCL reconstruction, how far are we from the neurovascular bundle. So understanding that where the anatomy is that you never get to see is a great thing. We also use it for courses. This is Lars Peterson, who's kind of considered almost like the grandfather or father of autologous chondrocyte implantation. He came over from Sweden. This was our articular cartilage course. This is Dr. Carey, who's one of my partners, who's the director of our cartilage restoration center at Penn. And this was a station set up for doing matrix autologous chondrocyte implantation. And in these things, it gives us that platform to really be able to do cadaveric education. Now, it leads to the next thing. And we don't have this yet at Penn, but we are really working hard to try to get this. It's virtual simulation. And so I looked at virtual simulation about 6 or 7 years ago, the first time, and it was cute. I'll say that, it was cute. You put the things in, oh, this is kind of cute, it's kind of like playing a video game, but it's kind of like playing Mario Brothers, and all it did is Mario just kind of ran around a room. There was no monsters, there were no bombs going off, there was no next levels. It was just kind of like, oh, we can just drive around, this is kind of cute, wow, this is pretty neat. But you didn't feel like it helped you. Now it has really changed. You can do arthroscopic procedures. You can reach in there and you can literally resect the meniscus. You can remove loose bodies. They're even going out to get modules for like doing ACL reconstructions. And it really is becoming a much more proficient system. This is just one of the simulators. You have knees, you have shoulders, you have hips. So you have just trainers that are just for doing skill sessions. And the images are very realistic. You can do just training modules where it's just like in a room here, and you're trying to just triangulate and do different things. This is like the shoulder. Here's the biceps tendon. You can do like biceps tenotomies. So I would say that they're still coming along, but they're so much advanced over where they were. And there's therapeutic cases, things like doing ACL reconstructions. You can do ACL reconstructions on these models now, and they give you feedback, which is great. They're very expensive, but they give you feedback. It allows us you can videotape them, So at a separate time, I can look at, flying out here from Philadelphia to Seattle, I could have popped them on my laptop, and I could have, looked at it and said, all right, see how someone's doing. So it gives you reports. This was one looking at basic competencies, and they had different tests at different simulators, just so there's different kinds of simulators. This is like what you see inside the knee. Sometimes they'll show a dot, and you have to touch it. So it teaches you kind of probing. You can see the meniscus in the back here. And they did 5 different things here, and they looked at experts, and they looked at residents, and you can see how the different things clustered. They kind of came up with a theory that where the 2 sites intersect, you could almost say that would be a pass-fail line, and that there was one attending who fell out here and probably really needed more training. And then there were some residents that fell down in here and actually probably were competent at the level of an attending level. You could see that you could really differentiate between these different groups. So what you're looking for when you're seeing these different things is you're looking for what's called construct validity, is you're looking to see, can you actually differentiate between groups, and can you use a technique and then see how it gets better with education and training? So it's cute to have these things, but is what you learn transferable to the OR, and does it measure growth? And those are important things in this process. And that's a little bit what these things showed, really, is that basically looking at the assay, remember the arthroscopic surgical skill assessment tool, looking at it basically scores before and after the different training sessions. And these are the things, now they're all being graded among themselves as far as how do they look, how do they feel? There's haptics, which means that when you touch something in the joint, you actually feel like that resistance of that femoral condyle. So we modeled, trialed a bunch of these and decided the simulator we want to get. Now it's just a matter of finding the dollars. We have a couple minutes left, seconds. I'm going to show this video here because this is the video that got swapped earlier. This was that one where we had that, actually it's the same ones we had. So this is the root tear avulsion in the back, and we see that in that location. On this picture over here, you'll see where that meniscus coming over, it's ripped right off of its root attachment to this location. And you can see this, we don't use these axial views much for meniscus, but sometimes they're really helpful. On this one, you can see the whole medial meniscus, and you can see where the tear is right in that back portion. And so this was really relatively solid tissue. So you had to visualize, can I fix this? We could put stitches in this, and then you have to drill a hole all the way through the tibia, and then you have to secure it. So we'll go with the final one. I don't think I hit, let's see, Jimmy. I didn't get Jimmy today. Where's Jimmy? Jimmy, all right? You get the final question. It's your honor, okay? If you're going to build an arthroscopic simulator, okay, and not the big one, not the computer one, okay, but just a simple Home Depot one or Lowe's, since I'm not sure if I have investments in either, so I'll use both. And so, and we need to reattach it to this posterior horn at the location of the medial meniscus, because, and why do we have to fix these things at all? Well, when you push down on the meniscus, it pushes out. What restrains it from going in an outwards direction is its attachments to the anterior and the posterior horns. The meniscus, medial meniscus, is going to handle 50% of your loads. Lateral meniscus, it's going to be 80%. So if you don't fix this horn, it's the equivalent of doing basically a subtotal meniscectomy. You've lost that function of the meniscus. So you want to try to fix these really whenever you can. So we go back to here. You see this is the tear. You say, wow, that's a pretty clean tear. Here's the edge of it right here. And you can see what I did to it. I put a suture in it, did a luggage tag, and then I drilled it all the way through the tibia. I tied it down over a button in the front, which is like a titanium button, and secured it and repaired it. And I want you to call attention to this. Look at her condyle changes. She's in her 50s. It's usually a person that's in their 50s. The tissue gets a little weak in the back. And the story is very common. I'm walking along, or I'm just moving quickly, and I feel like a sharp pop right in the back of my knee. It's not medial side knee pain. It's in the back of the knee. And sometimes it can be quite debilitating. If you don't fix this, this is just going to go, oop, and you're going to put all the forces on this area, and you worry about that. So you want to fix it. So Jimmy, we're going to come to you. You're going to build something in the lab from Home Depot, okay? What can you build to train yourself to do this? Maybe you can go also to Michael's craft store, okay? So what could you, let's start with the meniscus. What could you get to simulate a meniscus?
Rubber stuff or something.
Yeah, so a piece of rubber, piece of felt, some soft material, okay? And then what about the tibia? What could be the tibia? Like a platform. Wood. Okay, that helps me, because if I go to Home Depot, I go, do you have any platforms? They go, yeah, we got the ones that look to go right to the top, you know. So a wood block, okay? And then what would you do? How would you put a stitch through there? Now, you're making it on the cheap. You can't go and say, I need a scorpion or an espresso, and I'm going to bite and pass this arthroscopic suture through there. How could you pass a stitch through there? How about just a spinal needle? Okay, take a spinal needle, stick it through, slide a little PDS through it, tie a loop of suture, pull it back through. Now you got a loop coming through it. You know, the loop's coming through, up through the meniscus. You do a little luggage tag. Boom, we got a stitch now on that piece of rubber or that piece of felt. How are we going to attach it to the bone? Drill. You get a drill bit. Okay, drill it all the way through. How could you pass the suture through on the cheap? Okay, so you put the spinal needle up, and how do you get the sutures to come down? Or good. So you could feed a suture up through there, retrieve it, tie the sutures, pull it down. Then what could you tie it over? On the cheap. How about a button? A button, okay, it costs about 70 cents, or probably not even that, 8 cents. And so I'll give you this later. I don't usually wear a tie. This was a special honor for you guys. I wore a tie for you guys. So I'll give you my shirt later. You got all the buttons. And so, but tying down over the button, okay? So just when you think about it, you go, wow, that is kind of neat. You could actually do that. And if you did that just on your own, then when the day we got into the yard, and we now have biters that bite and pass a stitch right through it, and then you shuttle it through. But before we had that, I would make a posterior medial portal, and I would bring like something that's essentially was like a curved spinal needle in, and I would bring that in behind the condyle. I would penetrate right through there, and I'd feed a suture through. So it's almost like, goes back to the thing, you have to visualize, and you can simulate these things. And if you did that on your own, and the way you described it was great, but you could also, you could say, hey, I'll take a teeny wire, and I'll loop it, and I'll push it, slide up that little hole I drilled with the tibia through the blown block, the wood block, and then pull it back down. So if you can visualize these things in your mind, practice them, it will decrease the stresses before you get to the operating room. And so in conclusion, always prepare for your operating. We talked about arthroscopy today, but whether it's a total knee replacement, it's a spine surgery, it's carpal tunnel surgery, prepare. Think about your anatomy. You know, sometimes people just want to come and they want to learn all the steps. Know the anatomy that surrounds it. Utilize simulation. I put in quotes. It's not just the big simulators that cost $200,000. There's a lot of cheap simulators that you can do. It's the cadaveric training. Take notes this week in your cadaveric training stuff. You know, write things down at the end of the day. Be creative. Be involved. Some of the best accomplishments, you think of the things that you say, wow, look what they're doing. Let's see, we had a cadaver lab funded by a PGY5 of $580,000. We had video going in place by our PGY4. Many, many residents involved in putting together all the steps of arthroscopy. These are all things, dry lab that was put together by PGY. These are all resident-driven things. And none of us are telling the residents to do this. Our residents just go, yeah, I think I want to do this. And repetition leads to confidence, and confidence leads to proficiency. So thank you very much. Any questions?
Let people know remotely that they can text you.
Yeah, no, we got the little remote text thing here now. So thank you, Dr. Sennett. Some of those slides actually gave me a little bit of anxiety from remembering being back in your OR. And I don't know, you can ask my residents. I try to be just as hard on them about being very careful around the condyle. So thank you for that great presentation. And
if he is tough, just blame it on me, okay?
And a note to the residents, you saw what they were doing at Penn and some of the things that they're innovating to be better arthroscopists during their residency, and you guys have access to just about all of that, including said $200,000 simulator, right? That's something that Dr. Chansky invested in for us as a division and for you guys for your learning, and Dr. Kwan is spearheading that kind of effort. So make sure you do all those things, because think about, you know, the things that you have at your disposal that Dr. Chansky, or that Dr. Sennett was telling you basically you had to devise. You have all that here for yourself. So.
Dr. Chansky doesn't want that simulator to become a $200,000 hack rack.
Yeah.
Yes, as he's reiterated to me multiple times. Yes,
Yeah.
so
You know, I will tell you that it's that it takes structure. So like with a simulator, you have to have like a schedule, a goal, proficiencies, and you know we've actually already built a curriculum for it. Even though we don't have it yet, just so that, but it was part of the validation of why we would use it, what we would do with it if we got it, as we talked to people to get money for it. I will tell you that when Dr. Chansky and I trained, we didn't get to do a heck of a lot of stuff. And I like to think I've become proficient in arthroscopy. I always feel weird saying expert. But the proficiency, and it's, but we learned the basics. We learned, you know, I watched a lot when I was a resident. You know, the only time you really did stuff as a resident back in the old days was when the attending sometimes left the room. And you know, and that was your time to practice some of these things. There were no cadaver labs, there were no simulators, there was nothing. It was just, and then you got in practice. And then it was up to you to push your own education. And just like he's gotten proficient, and I've gotten proficient, you too will get proficient. The question is, when do you become proficient? Do you become proficient before you're done? Or do you become proficient a bunch of years down the road, like kind of what we did? And so a lot of this stuff is about how to get proficient, how to feel confident in it. One of the neat things that I watch as residents go through their training is watching your guys' confidence levels grow as you go through it. And that chief resident who can now, you know, rod a femur without any difficulty at all and take the tooth through it, it's like, wow, that's fun for us to see your educational growth. So.
we have a couple minutes for questions from anybody in the audience. Chris, you want to?
Thanks so much. Is this on? Yeah. Thanks so much for coming. Haven't had a chance to meet you yet. I'm Chris Kwan, one of Dr. G's partners in sports medicine, and really appreciate that talk. And I wanted to maybe comment more about the point that you make about proficiency, something that I think all of us are still striving towards. Never would think of myself as being an expert or proficient at arthroscopy. And one of the lessons that I try to impart on the second-year residents that are on service on sports is that confidence and comfort comes from reps and repeated banked physical movements and volume, but also more important than that, probably the confidence coming from preparation. And so of all the things that you listed, talking about those notes that residents made and the time they put on their dry lab and knowing the surface anatomy and thinking about it and watching videos, whether they're the ones of the actual surgeon or on YouTube or ViewMedi, but that kind of thought process is as important to the confidence as the actual doing of the moves. And you guys, I know that the residents joke about me not stressing the moves of surgery, but more about the process and the thinking involved in what you're trying to accomplish and what you're trying to do. And so I think that's kind of a nice point to make about the confidence coming from the moves that you get to do, but also the lead up and the thinking that goes into that process. So I really want to say thank you for pointing that out.
Yeah, the thing I'd add to that is that we'll have some residents that will come through and they'll be really good. They'll have all these steps like that, and then one thing changes. Something happens. The patient starts coughing, and the knee starts bouncing, and and then it's like, and then it's all of a sudden they're lost. Like they were doing great, but something just threw it. They got a distraction. Something happened in the middle of the thing, and they lost that big picture. So you need both. There's that old saying, the forest and the trees. You need to understand the details, but you need to understand how those details fit into the big picture. The other thing is, you learn more as you, this is going to sound silly, you learn more as you learn more. What I mean by that is, if anyone watches the Food Network, anyone watch the Food Network channel? Not that many. I watch the Food Network channel. That's my disclosure. I should have just put a disclosure sign. I have nothing to disclose other than I watch the Food Network channel, and I've known these guys for many years. So, but the reason I bring that up is if you cook something one time and you watch the video and you do it, the next time you see it, you're looking at different things. You're looking at, did they level off that tablespoon? Did they do this? What was the order they put it in? As opposed to just going, okay, let's see. Giada De Laurentiis says to do this, 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 and it's a recipe. And okay, I'm going to do that, and you do all that. Now, if you know how to do this, now you actually watch the video of her doing it. You go, wow, look at that. Okay, you pick up other things. You're so preoccupied the first time with just understanding the steps, you can't learn that next level. You actually have to learn this base before you can learn that base. If you look at a professional basketball coach or professional baseball, they look at a baseball game very differently than you and I look at a baseball game, because their level of education in baseball or basketball is so much further that they see deeper into that game because they are at that higher level. That's what you want to get before you get to the operating room. You want to get the mundane stuff out of the way. You want to know how to tie an arthroscopic knot. Because if you don't, and Dr. G showed you 3 weeks ago how to tie one, and you didn't write it down and you didn't do it, you are going to be stressed. And it's like, oh, I should have. And then if you say, here, let me show you again. Now your stress went to disappointment, and now your brain's kind of shutting down, and you're not learning. So the more you prepare for it, and if he or I or Dr. Kwan says, do you remember how to tie that knot? Yep, I do know how to remember to tie that knot. Now you gain confidence. They're excited with your educational work that you did outside, and guess what? You get to do more. Every time you please us, you get to do more. When you displease us, you do less. So the more you prep and do things that what your attendings want you to do like that, it's going to help that educational process.
I'm Jared Harwood.
Yeah.
Thank you for joining us. I was wondering if you took the time when you started your journey in orthopedics to now, when did you identify yourself as a teacher? And how are you a better teacher now than when you first started teaching?
I truthfully, I'll take the first part, the teaching. When I became a teacher, as a resident. Residents teach each other. And, Howard taught me, but he wasn't, Chairman Chansky, and I wasn't, Vice Chairman. It was, he was the PGY4 and I was the PGY3, we were a CHOP together. So you're teaching each other, and, we get to, when our residents pick the rotations, they sit in a room probably the same way you guys do. You sit in a room and you start going, okay, who goes first? And then it's just all the things start to fall into place. And you may want that rotation, but this one boxed this one out and this one this thing, and all of a sudden you kind of get that first choice, and all of a sudden the schedule just kind of makes itself. The biggest determining thing in our residency for the threes is who they have to work with on trauma as fives. Okay? Doesn't have to do with the attendings. Doesn't necessarily sometimes have to do with what specialty they want to go into. It's like, what five am I working with? Who's a good teacher? Who's going to help me with my education? Who do I like? So my thing started as a resident. Residents teaching me, and me wanting then to pass that to my residents. And then it kind of snowballed from there. So I always enjoyed education, and I always got a lot of enjoyment out of seeing people grow. And that's one of the great things. It's, so that was the first part. What was the second?
How have you
how have I improved his attention?
Now than you were, say, 10, 20 years ago?
I'd like to say I'm more patient, but I'm not. I think I'm better now because I individualize training a little bit better. I'm better now at recognizing who I have to teach differently. I taught, when these guys came through, I taught them all the same, and most of the time they were a circular peg in a circular hole. But every time I get a square every so often, you know what, I could just beat that square peg into that round hole, and it went. Some of it had to bash it on the sides a little, but I got that in. Now my wife is my nurse practitioner, okay, and she's in the OR with me, and sometimes we'll drive home, and she's been a great mentor to me. Sometimes she goes, why do you beat him so hard? He's not going to get it. I go, and we'll all be driving. I go, I will not accept that. And but over the course of the years, I realized that residents, we learn differently. We learned, some I have to go to a slightly different approach. I don't lighten my standards for them, but it's something I have to be more creative. I have to talk to them more. I may spend more prep time talking about, let's talk about the case. We prepare for cases more now. The truth is, when these guys were here, we just go to the OR. But they spent all the time with me in the office. Like every person I saw in the office, they saw. So now we have, on one day the resident's not there because they're post-call. So we go over a little bit more pre-op planning. What's the game plan? What's the goals? This is what I want you to read. So I give them better goals. I think that one of the things that we're supposed to do as faculty members through ACG, we're supposed to meet with them at the beginning of rotation, halfway through, and at the end of rotation. I think those are very important things. And I used to think that was silly because I thought, why do I need to meet them halfway through? I am not a shy guy. Like I always tell people, I never give false praise. If you do a good job, I will tell you. I will never tell you did a great job if you didn't. And there's feedback every single day. But it's still important to have that time where you sit down and you say, okay, this is where I think you are. And out of the context and the heat of like the OR and stuff. So.
It's interesting, you said, with the ambulatory surgery centers, you have the time pressures, but it seems to me like you're describing a much more time-intensive teaching modality where they may not be physically with you as much, but it requires more prep time and more talking and more.
And the other thing that it does.
How do you reconcile that?
Yeah, it does. And what I do is I tell the resident, every case, there is something educational about the case, and I will tell you what it is, okay? For an ACL reconstruction, I will just tell you, when we do an ACL reconstruction, I make all the portals, I do the whole meniscectomies, and then we have the time for the ACL. That case is about ACL reconstruction. It's not about making that portal. It's not about cleaning up those meniscus. That learning, I think, will be for the knee arthroscopy. So every case has to have a goal, okay? And you have to have some time. If I have, the other day I did a case, and it was a ACL reconstruction with a peripheral medial meniscus tear with a root tear avulsion of the lateral meniscus. Okay, so I did a medial meniscus repair with sutures. We did a pull through on that one, and it was Friday, and I had no more cases afterwards. That case, if I just did it myself, I don't know, it'll probably take me 2 hours to do. I think we were in there for 3.5 hours. And the nurses are like, are we going home today? I go, we have no more cases to do after this. They go, exactly. But you know what? And we put 3 sutures in the thing. I put the first one in, the fellow put the second one in, the resident put the third one in, and you tailor make it. But if that wasn't the last case of the day, you'd be like, all right, I'm gonna do the meniscus stuff. Boom. But that meniscus repair, if that's that time, this case is maybe not so much about the ACL, it's about this. You have to tailor the case.
Thank you.
Thank you. Thanks for being here. Thanks again, Al.